Okay, hello everyone. This is Vicky, and welcome to today's bioscience seminar. I want to say first is Andrew will have a clinic in the afternoon, so our talk will finish a little bit earlier, like 12:50, and we don't have the follow-up sort of the discussion with our speaker. But since Andrew is in-house, his office is just on the second floor. So we are planning, if you are interested, we can have a group meeting at a later time if you have questions. So I will start the introduction first. It's my pleasure to invite Dr. Andrew Portuguese to give his talk at our bioscience seminar. Andrew is an assistant professor at Fred Hutch and the physician on multiple myeloma and a member of blood and marrow transplant and the immunotherapy program at Fred Hutch and UW. Andrew got his bachelor degree in physics, and must be some great reason or something he changed to medical school. And he got his MD and resident at the University of Rochester, and he come to Hutch in 2020 as a fellow for HEMONC and become faculty assistant professor in 2023. So to be honest, I feel like he's already an associate professor because I studied him for a very, very long time, His research focuses on cellular therapy for malignancy, including CAR T-cell therapy, auto stem cell transplantation, and real-world outcome research. His work emphasizes on causal inference method applied on the observational data to address some questions that cannot be answered through the randomized trials. That's his topic today. And also, I want to say Andrew is very, very interested in learning cutting-edge statistical algorithm and how to apply those methods in clinical research. And also, he is a great R programmer, and we have a lot of collaboration. And basically, all the R code he wrote himself and generating the R markdown himself. I just review his 5,000 line of the code. I work with Andrew and Ted for teaching the foundation in biostat and R for 2 years class to HEMONC fellow. Probably not this year, I guess. And his R workshop is super popular. So I feel like Andrew is a perfect fit as our biostat audience. Some people, some clinicians who is interested to know more about biostat, and also his work is very related to how to apply our algorithm, biostat algorithm on the real world data. Today, Andrew will present estimating treatment effect without randomization, propensity score in real-world oncology studies. Again, he had a clinic in the afternoon, so he will leave early. So if you have questions, I encourage you to ask in the middle of the talk, and we will make sure to let him go by 12:50. Thanks everyone for coming. Welcome, Andrew.
Thank you so much, Vicky, for the introduction, for inviting me to be here. I'm Andrew Portuguese. I'm a clinician in the transplant immunotherapy group. I'm focused on multiple myeloma, and a lot of the work that you'll see today has really come from arguments. When different groups agree, when the transplant group doesn't agree with the myeloma group or the lymphoma group, what's better? What should we do in a given situation? And how do we really answer the question and satisfy everybody? And so a lot of the work has really come from these disagreements and trying to get to the bottom of what is true and what is just opinion. Mo chemo, mo problems, a famous quote from the notorious B.I.G. I'm going to start by going into a clinical vignette to try to explain this first project. So this is a 69-year-old patient with high-risk multiple myeloma. She had previously been diagnosed with a precursor condition, MGUS, and her biochemical parameters of this were increasing. By 2019, her M spike had increased to 2.8, which is pretty high. In 2020, she started having lesions on surveillance imaging. And then finally, in October of 2020, she had 90% involvement of her bone marrow with abnormal plasma cells. She had a complex karyotype. She had 2 high-risk cytogenetic markers, and her parameters continued to worsen. She got 6 cycles of treatment back in 2020. She was treated with CyBorD. We now use usually Dara-VRD, but back then CyBorD was more standard. And she achieved a very good partial response. And so her M spike decreased from 3.1 down to 0.3, so about a 90% reduction in M spike. So decent response. But in her pre-transplant workup, and in myeloma, we sort of debulk and then we launch people into transplant typically. In her pre-transplant workup, there was still quite a bit of disease in her marrow, between 10 and 20%. And we usually want to see less than 5% to take somebody to transplant. So really way too much disease. And her PET-CT still showed some residual small volume disease. And so when she arrived to the transplant service, she was told, essentially, you have too much disease and you're not a good candidate for transplant as things stand currently. And so there's really two options. And they wrote in their note, to improve your odds of a durable remission post-transplant, we recommend achieving better disease control. And there's really two different strategies to do this. You can go home to where you came from and get another few cycles of some different, more intensive chemo regimen, or we can do what's called intensive chemomobilization, where we hit you with a 7-drug, really aggressive regimen, and then as soon as your counts recover, we collect your stem cells right after that. So it's sort of a strategy where you collect off of the wake of the chemotherapy. It's sort of like just-in-time chemo. Surprisingly, with this approach, you can actually improve stem cell collection yields. It's a little bit paradoxical, but you can improve collection yields, you can debulk disease potentially. But what's the evidence for doing this is sort of the question. So she ended up choosing the chemomobilization route, not the go home for more therapy. And she was admitted for KRD-PACE, which is a very aggressive multi-drug chemotherapy regimen. And then she ended up getting a neutropenic fever, requiring a readmission to the hospital. There was no source identified, so it was just a fever, not like an abscess or something. And she collected really well. She collected 11 million stem cells per kilogram, so did great with the collection. And then unfortunately, post-chemomobilization, she had even more plasma cells. So it really didn't move the needle at all. She had 25% now. She ended up proceeding with stem cell transplant despite this, and had a 15-day admission for this. She had another neutropenic fever. She had CMV reactivation, and so there were some complications of it. But overall, she tolerated it okay. In the post-transplant assessment, her disease parameters pretty much normalized. So in myeloma, we looked for the M spike and the free light chains, and those normalized. Her bone marrow biopsy still showed a very low level amount of abnormal plasma cells by flow cytometry. And so she basically achieved a complete response, but not a stringent complete response, and with MRD positivity. And she was started on a high-intensity maintenance regimen. But then a year later, and so normally with transplant, we expect to get several years. In 2026, we expect to get maybe 10 plus years out of a transplant. For a myeloma patient, she got 1 year, and she had progressive disease, new lytic lesions on her PET scan, worsening free light chains, and this continued to worsen. Her free light chains increased rapidly between June of 2022 and July of 2022, from 130 to 450, and her treatment was changed. It worked a little bit. It was intensified when it stopped working, and then she started having issues that led to her death. And so the question is, did this patient benefit from intensive chemomobilization, or was it futile? So most patients with myeloma don't get chemomobilization. They get debulking with standard induction, and then they just collect stem cells without any additional further chemotherapy. And we use GCSF and sometimes plerixafor. And this strategy is very good at collecting stem cells, but it has no impact on disease control. So chemomobilization can be used for two things. It can improve the collection yields, kind of paradoxically, and it can potentially debulk tumor. When we add on the second medication, plerixafor, we can boost the collection yields. And so this first point is maybe less relevant. We really don't need chemomobilization to boost collection yields anymore. But who really needs debulking of the tumor anyway? At what point is disease too much disease? What parameter of disease do we say is the threshold for having too much disease? So where do you draw the line? Who do you select to use this intensification? And why not just give high-intensity maintenance? Why treat on the front end when you can just give high-intensity maintenance on the back end? So do you need to debulk somebody before transplant when you can kind of debulk them afterwards? And then if you can't cure anybody, then does any of this really matter? Can we just treat somebody once they relapse? So using chemomobilization has been very controversial, and historically only Fred Hutch has really done it. And it hasn't really spread beyond here. It's kind of been a Hutchism. And so most studies of chemomobilization have focused on just a single agent cyclophosphamide. And so I would label this as non-intensive chemomobilization. It is chemotherapy, but it's not really doing very much to mitigate excess disease burden. And so it's very well established that you can collect more stem cells if you mobilize off of the count rebound after giving the cyclophosphamide. But there are some more complications. There's no clear cytoreduction, so you don't clearly reduce disease bulk. And there's no improvement in long-term outcomes. And this is a fact that has been proven like time and time again, looked at a bunch of different ways. There's no clear signal that giving chemotherapy with cyclophosphamide improves anything long-term. And so GNP or G-CSF with or without plerixafor is considered the standard of care for mobilizing patients ahead of a transplant for myeloma. Intensive chemomobilization with CARE-D-PACE, it's a 7-drug regimen. It's been studied at Fred Hutch. Its use has been sort of inconsistent. But the main indications, if you will, for the kinds of patients that typically receive this treatment are people that have circulating plasma cells at the time of their pre-transplant workup. So if we do flow cytometry of the blood and we see that there are circulating plasma cells, that's really concerning. The concern there is that if we do a stem cell collection, maybe we suck up some of those plasma cells and then we just give them right back. And in fact, the patients who have circulating plasma cells typically only get about 1 year of disease control with a transplant, so that's very high risk. People who have more than 10% bone marrow plasma cells, it's certainly not a hard cutoff, but that's typically the cutoff that's used, and some of that comes from our pathologists, that they'll often say, like, it's less than 10%, or it's more than 10%. And they kind of categorize how they treat the plasma cell burden in the marrow. It's not so continuous in terms of how it's reported in the pathology reports. And then the monoclonal protein, the M spike, if that's more than 1, that's pretty high. And if the involved free light chain is more than 10, that's pretty high. So those are really the 4 things that, when this was analyzed, how are we actually doing this at our center, kind of emerged as the quote unquote indications for this. But certainly some attendings don't believe in it. Some use it when it's not sort of so clear cut, doesn't fall into one of these categories. And so there's some wiggle room where it's not used, like there's not a protocol for when to deploy it. In this study, the objective response rate to using the intensive chemomobilization strategy was 50%. So patients did respond. It was able to debulk them ahead of the transplant, but there was some serious toxicity. The majority experienced grade 3 to 4 hematotoxicity almost by design. This is almost like a mini transplant, really. And a quarter required readmission after an initial admission for the infusional chemotherapy. So really resource intensive.
Andrew, I have a question. It's probably relevant to the ultimate topic. But is there no way to use technology to pull those plasma cells out of a biopsy?
Well, it's sort of a question of, is it the plasma cells themselves, or is it a biomarker for just they're spilling out into the blood because there's just so dang many of them? It's hard to know. Yeah. I personally think we're probably taking them out and putting them right back, but I do not know that. That's just kind of my gut feel. Yeah. But it is definitely a biomarker. But there isn't really a clear selection. When we collect the cells, what we're doing is we're centrifuging the blood, and we're collecting the layer that contains the stem cells, and so it's nonspecific. And then we're counting the CD34 positive cells, but the total nucleated cells is way higher than the CD34s. And some people collect more or less efficiently, and so the ratio of stem cells to everything else is very variable between patients. And so it's not a super precise procedure. Yeah. And so we wanted to address this question. Really, where this project came from was a disagreement between the transplant service and the myeloma service. The transplant service felt like we've been doing this for a long time. Our expert opinion is that this works, this helps patients. And the myeloma group said, nobody else does this. Why are we doing this? And then leadership kind of said, well, this is very resource intensive. If we shouldn't be doing this, we need to stop. And so that was sort of the motivation for trying to do this. And so we needed causal inference methods in order to understand our data. So we looked at patients who underwent stem cell collection using intensive chemomobilization with intent to proceed to transplant, and also looked at patients who did not use intensive chemomobilization. And we looked at patients between 2020 and 2023. And so we excluded patients if they were planned for or received a tandem transplant, so basically 2 auto transplants in a row, who had primary plasma cell leukemia. This is sort of an ultra high risk. Some people think about it as sort of a separate thing. Some people think about it as a variant of myeloma, but it does have distinct disease biology, and there's not that many cases of it, so we excluded that. Anyone who received non-intensive chemomobilization, so if they received just cyclophosphamide, we weren't sure how to handle that, and so we excluded those patients. And if somebody received chemomobilization because they failed a regular GNP mobilization, so we were really looking for people who kind of had the indication of they were getting this because somebody decided that they needed disease debulking. And so these are the characteristics of our patients, and we had 451 patients who underwent transplant. And the vast majority, 86%, just got G-CSF with or without plerixafor. But there were 13.5% of patients, or 61 patients, that received intensive chemomobilization. And there were two main regimens used, PACE and hyper-CVAD. For the purposes of this analysis, we kind of treated them equivalently, but the majority were PACE-based. All patients who underwent the intensive chemomobilization ultimately did go to transplant, and so everybody was evaluable. There were very obvious baseline differences between the intensive chemomobilization and the non-chemomobilized patients. The disease burden markers were all dramatically worse. The percentage of patients with at least 10% bone marrow plasma cells was way higher. I'll use this. So way higher in the intensive chemomobilization versus the chemomobilized group. So 48% versus 3%. And the response depth was also much better in the non-chemomobilization group. So 90% had at least a very good partial response versus 38%. The involved free light chain level was higher in the chemo group. The M spike was higher. There were more circulating plasma cells. There were more with high-risk cytogenetics. More received full dose melphalan. There's sometimes dose reductions in melphalan. Because Ted's not here, I did add p-values to this table, and I sorted by p-values. I know he doesn't love that. But these are the things that were most different in comparing these two populations. And so what were the rationale when you look at the notes for these patients? Like what was the treating clinician thinking? Well, the major reason for deciding to do chemomobilization was having bone marrow plasma cells of more than 10%. Sometimes patients also had evidence of progression of disease right before, and people wanted to get that under control. Other reasons, so patients who just didn't quite have a very great response, so a partial response, or having circulating plasma cells were other reasons. When we look at the impact of chemomobilization across the whole cohort of the 61 patients, the response rate was 31%, and you can see that the response depths improved. And so this is the VGPR rate in blue. So it went from 35% to basically 59% had a VGPR or better. And so we've really increased this proportion. And in general, when we think about eligibility for transplant, we do want people to be in a very good partial response or better. And so we really were pretty successful. We basically doubled or not quite doubled the percentage of people who got into a VGPR right before transplant. And we saw that when we look at the biochemical markers, people did have improvements. And so the top is their M spike, which is the total amount of abnormal protein made by the myeloma. And we're seeing that in general, people are having decreases in their M spike. There were a few that worsened. And then we see that their free light chains are also generally more likely to be improved than not improved with the chemomobilization. And then 63% of the people that had circulating plasma cells cleared their circulating plasma cells. So it does seem like certain disease parameters are fixed or improved by doing the chemomobilization. There was a lot of toxicity. So 18% required readmission. So it's like a 5-day admission to get the chemo treatment, and then they're discharged. 18% required readmission, but all patients ultimately did proceed to transplant who underwent the chemomob. When we look at event-free survival defined as progression, death, or starting a new non-maintenance line, so basically if somebody's progressing, the people in the chemomobilization group did very badly. Their median EFS was less than 3 years at 34 months. It's very significantly worse than the non-chemomobilized group who just got G-CSF. And so when we look at this, it's pretty easy to just dismiss doing this and say, this is like a horrible thing to do to people. Why are we doing this? We're wasting resources. We're giving people infections. They're spending more time in the hospital. Why don't we just transplant people? The overall survival was also a lot worse in the people that get chemomobilization. What if we adjust for confounders? If we look at the things that impact overall survival in a multivariable model, Having high cytogenetic risk matters, having circulating plasma cell matters, having progressive disease or a partial response at time of transplant matter. But then intensive chemomobilization really straddles the line and doesn't seem to really matter. What about event-free survival? Same thing. Intensive chemomobilization straddles the line and doesn't really seem to matter. But is multivariable analysis sufficient? Are we comparing apples to apples? We're sort of looking at the independent impact of chemomobilization, but we're not comparing patients who got it to patients that look like the patients that got it. We're comparing patients that got it to everybody. And so enter propensity score matching. What is propensity score matching? And I know that I probably don't need to tell you what it is, but I'll review it. It's a way to reduce confounding by indication, because clearly patients who get chemomobilization and other kinds of more intensive treatments, they're not the average patient. They're somebody who's sicker, who has higher disease burden, who has worse parameters in some way to warrant giving them something more aggressive. And so the goal is to reduce confounding by indication in observational studies when randomization is not possible. We can't do a randomized controlled trial. Well, maybe we could, but it would be very hard to fund it. It's not something that's really practical to do in this instance. And in many situations, you can't just do a randomized trial, and so you have to work with what you have. And so we want to compare the treated patients to untreated patients with a similar indication. And so the propensity score is very simply the probability that a patient receives a treatment conditional on relevant baseline characteristics. And so, in this case, all the different things that are sort of indications for chemomobilization, the things that we think increase the likelihood that somebody will get it, these are things that want to be included in as conditionals for the propensity score. So why do we need it? Well, the treatment assignment in real-world data isn't random. Sicker patients are more likely to get more aggressive therapy. Multivariable models may not adequately balance the groups. And so what does it do and what does it not do? It improves comparability between treatment groups, and it balances measured covariates. And so propensity score matching allows us to determine something called the average treatment effect in the treated. So among patients who get a particular therapy, is it useful? So we're taking a look at, we're focusing a spotlight on patients who get a therapy, and we're creating a pseudo population of patients that didn't get it, but could have, because they resemble the patients who got it. And then we can compare apples to apples. We can compare patients who are very comparable and look within that population, is there a positive or negative impact of the treatment that was given? And so it doesn't recreate a randomized control trial. It cannot adjust for unmeasured confounders. But in many cases, it's the best thing that we have to approach causal inference. And so what are the key steps? So you estimate the propensity score. There's different algorithms for doing this. Often logistic regression is used using relevant baseline covariates. And then you use the score to balance the groups. In propensity score matching, the two common ways to do it are one-to-one nearest neighbor matching and optimal full matching, and I'll talk about what those are in a couple of slides. And then you assess the balance, and so you can use standardized mean differences or variance ratios. I'll talk about that a little bit in a couple of slides. And then you estimate the treatment effects. And so then you can just run a regression model that's weighted, or you basically just use a regression model based on the downstream, the output of your propensity score matching. And so what are the things that were associated with receiving chemomobilization in our data set? So the M spike being higher, so treating the M spike as a continuous variable. As the M spike increases, you're much, much more likely to get chemomobilization. If you have more than 10% bone marrow plasma cells, you're much, much more likely to get chemomobilization. Same thing with circulating plasma cells and involved free light chain. So the things that were felt to be indications in the historic data set really did drive the likelihood of getting this. And so then you can generate something called a love plot. So if you match with these covariates, you want to know how good is the matching. And so if we match on the indications for chemomobilization, bone marrow plasma cells over 10%, M spike is a continuous variable, circulating plasma cells, yes or no, involved free light chains is a continuous variable, then we can compare the absolute standardized mean difference. So basically comparing the means before and after matching. And so the red is before matching. And so we see that things like bone marrow plasma cells and M spike and circulating plasma cells, these are not balanced. And obviously, as I showed before, the patients in the chemo group are much more likely to have adverse parameters. So more bone marrow plasma cells, more than 10%, higher M spike, more circulating plasma cells. And so then there's two different methods, nearest neighbor matching and full matching. And in these models, optimal full matching was the best. So we were able to balance, particularly the bone marrow plasma cells, better than nearest neighbor matching. How do you interpret one of these plots? Well, if the SMD value, the standardized mean difference value, is 0, that's perfect balance. If it's less than 0.1, that's really, really good balance. If it's 0.1 to 0.2, it's mild imbalance, and if it's more than 0.2, it's a meaningful imbalance. And so, this is not perfect, and that's something to keep in mind. That oftentimes the balance will not be perfect, and so you kind of do the best that you can with it. And in this case, the bone marrow plasma cells in particular, they're still worse in the chemomob group. And the circulating plasma cells are still worse in the chemomob group. We can also look at balancing the variance. And so when we look at the M spike and free light chains or continuous variables, we generally want the variance ratio to be between 0.8 and 1.25. So we don't want there to be totally different distributions of these continuous variables in our two models, or in our two populations, our main treatment population and our pseudo population. And so with the M spike, that's pretty well balanced, it's 0.87, but the involved free light chains are totally imbalanced, very, very imbalanced in terms of the variance. And so when we look at the distribution of M spike, this is before matching and after matching. It's not a perfect distribution, but the variance is similar. When we look at the involved free light chain, there's one outlier in the chemomob group who has a ridiculously high involved free light chain that we cannot match. So there's one patient that's driving this to be really, really high. So I'll come back to that in a little while, but just keep that in mind for now. So what is one-to-one nearest neighbor matching? It's really pretty simple. You're basically for every treated patient, you're finding the closest non-treated patient. And so it's basically based on the closest propensity score. So for every propensity score that you generate for the patients who receive a treatment, you're finding the closest one in the untreated group. And you're basically finding, like, what's the way to find the nearest neighbor to every matched patient. And so it kind of looks like this. So these are the chemomob patients up top, and then these are the matched control units. And so we're taking the patients who have the most similar propensity scores, and we're discarding a bunch that are too low, essentially. And so it's really easy to do this. It's easy to explain. It's easy to interpret. It kind of mimics a traditional matched cohort. It's commonly used. It's widely understood. But you're discarding unmatched patients, and so you're reducing your sample size and precision. And particularly when groups are really imbalanced, it just doesn't perform as well. What is optimal full matching? And so this creates matched sets where there can be one treated patient and many controls, or many treatment patients and one controls. And so it's a way to use all available patients and essentially create like a Frankenstein. You're creating like a chicken nugget that sort of resembles your matching patients. Like, I don't know if any of you have seen the movie Moneyball, but instead of like buying one player that's like an amazing player, you might buy 3 players that have, like, one is really good at getting runs, and one is really good at stealing bases, and one is really good at catching, So instead of having one patient that is really perfect, you have several that, when you average them, they create your perfect patient. And so that's what optimal full matching is doing. And so it's less intuitive. You're kind of matching by weighting. It's a much more complicated procedure to do it. And so individual patients can contribute less than one effective observation. And so it's more confusing. And so it's something that you should really reserve if you need it. So what are some practical considerations? So in one-to-one neighbor, you're always going to have some that are discarded. In optimal full matching, everyone is retained. One-to-one nearest neighbor, it's very simple. Optimal full matching, it's less simple. Balance with strong indication bias is, it's usually superior with optimal full matching than nearest neighbor. The power is generally always higher with optimal full matching. And, one-to-one nearest neighbor, if you have really well overlapping groups, if you're doing like a massive CIBMTR analysis and you have thousands and thousands of patients and you can find perfectly matched patients, it certainly makes the analysis simpler to do one-to-one nearest neighbor. But if there's strong confounding by indication and you want to make the best use of your data set, then optimal full matching is usually the way to go. And so one-to-one matching prioritizes simplicity, but optimal full matching prioritizes balance and precision. And so, it's like, do you just need to get from A to B, Or do you need like a performance machine? It really depends on what you want to do. Not everyone needs it. I don't need it for, not everybody needs the most complicated methodology. And so when we look at the baseline characteristics before and after matching, we see that they're improved. So we're creating a better, more balanced pseudopopulation. And so the M spike, it's much more balanced. The circulating plasma cell percentage, it's much more balanced. Bone marrow plasma cells over 10%, much more balanced. Involved free light chain, same thing. And so we're doing a better job. These are more matched. There are some things that you can sometimes make worse. So the RISS stage 3, so this is becoming less relevant, but it is something that's predictive of post-transplant outcomes. We make it a little bit worse. And then melphalan dose reductions are become a little bit higher in the chemomobilized group. Well, they started higher and get a little bit more imbalanced. And so when you do the balancing, you can inadvertently make certain things a little bit less balanced. And so this is the original multivariable analysis for overall survival. And then here's what it is when we do it again after propensity score matching. And so this is like a weighted multivariable analysis. And we see that, not huge differences, but it looks like intensive chemomobilization starts to shift over to the left a little bit. And then here's the EFS original multivariable analysis. And then here it is with after propensity score matching. So this is sort of the ultimate result of this process with this data set. But is this in and of itself convincing? And so I'm curious, how do we know that a propensity score matching analysis isn't just p-hacking, that we're not just randomly choosing things until we get a good p-value? Because I think certainly some people do use it that way. So how can you evaluate, was something done rigorously and fairly, or were specifications just chosen purely because it optimizes the p-value? And so there really needs to be a single unambiguous primary analysis that's defined ideally before the outcome evaluation. This should be based in expert opinion or in structures of the data set, precedent, prior literature. It shouldn't just be arbitrary. It should be justifiable, defensible. And so when we came up with our primary analysis, we used the things that were the indications for chemomobilization, and we tried to limit how what we included as covariates to things that were the most defensible things. The separation of the design from the analysis. And so, when you're looking at a propensity score matching paper, there should be a very clear section on here's what our covariates were, here's why we chose our covariates, here's the balance of our covariates, here's the variance ratios of our covariates. So kind of the model, how they justify the model, the diagnostics of the model, and that needs to be really separate from the reporting of the outcomes. And there should also be transparent reporting of pre and post matching balance, because sometimes it can get a little bit funny when you balance for some things, it can make other things worse. And so having a table that sort of visualizes all that data, I think, is really key. The sensitivity analyses have to have a purpose. Some people will just do like 1 million sensitivity analyses with every possible iteration and say like, well, the majority of sensitivity analyses agree. And that's not necessarily a good strategy. Every sensitivity analysis should address one criticism. They should be done with a purpose. It shouldn't be iterative tuning based on statistical performance. You're just saying like, if we do every possible iteration, this % of them are what we want to see. It should be really addressing a specific criticism and be done thoughtfully. There can't be cherry picking of favorable specifications. And all the sensitivity analyses ideally should be shown together so that you can easily compare what's the magnitude of the effect size, do they all agree in terms of the direction, and are the confidence intervals wildly different if the strategy changes. And so a single forest plot or summary table is a really good strategy. And there shouldn't be like selective omission of things. And so the effect sizes are really important, not necessarily the thresholds when you're looking at sensitivity analyses. You kind of want to see agreement. And so, if a p-value in one is 0.04 and one is 0.06, but the effect size, the confidence intervals are the same, the sensitivity analyses agree. So you really are looking to see that the pattern is very similar when you change the strategy. And so, that didn't really work very well. So I'm going to show you some sensitivity analyses. So one issue one question is, how does the bone marrow plasma cell percentage influence the hazard of event-free survival? And this is a little bit funny because we're kind of compressing information from the pathology reports. Sometimes they'll give a range, and when a range is given, we basically took the average. And so it's a little bit imperfect doing it this way, but when you treat the BMPCs as continuous and you look to see like, well, where does it start to matter? It might start to matter at 5, maybe it starts to matter at 10. But clearly once it's above 10, 15, 20, it really increases the hazard ratio of event-free survival. And just a nod to Jordan and Vicky, this is their methodology using a restricted cubic spline with 3 knots to do this visualization. And so what if we use a BMPC threshold of 5% instead of 10% in the primary analysis? That doesn't really matter. What if we treat it as a continuous variable? That doesn't really matter. And so we can see that the magnitude, it's basically the same, 0.3, 0.3, 0.4. The confidence intervals are basically the same. The significance levels are basically the same. So it's, these are all very convergent results. So how we encode the BMPC percentage doesn't really change the downstream outcome. What if we include high-risk cytogenetic abnormalities as a covariate in the propensity score matching model? That doesn't really matter. What if we include disease status? That matters a little bit, but really doesn't make a huge difference from the primary analysis. What about the involved free light chain outlier? So this is one patient who has this ridiculously high free light chain. When we get rid of that one patient, then our free light chain variance ratio is 1.9, which is now more acceptable. And so we can see that the distributions are more overlapping of the involved free light chain. And so once we remove the free light chain outlier, it really doesn't matter. So if there's one patient that is sort of like an outlier for one of the characteristics, it doesn't necessarily have a huge impact on the downstream results. Yeah.
So when doing the matching, usually I think that like every patient has to be eligible for either intervention. So is that outlier patient eligible for either of the treatments?
Yeah. Well, so with transplant, how do you decide who's eligible for transplant? It's so sort of clinician dependent, and there's been so much variability. And I mean, I think some of it is people who are more or less expert, like some people slip through who maybe shouldn't. Some people have differences of opinions. Some people say like melphalan is just another line of therapy. Who cares? Let's just give it to them and whatever happens, happens. Some people say, no, we want to optimize them for transplant and this matters. So people really think about it historically very differently. And so who's eligible for each one? There's a lot of overlap.
So that's interesting in and of itself that it's the patient, it's the provider.
It really is. It really is. And sometimes patients, well, and sometimes people will get chemomobilization for really silly reasons that are like hard to even understand. So there's a little of everything in the data set. It's kind of like, it's one of these weird hutch things that it's not well standardized within our center and nobody else does it. And so the question is, does it help? And it's resource intensive. So it's like, let's not do it if it doesn't help. And so, oh yeah, oh my gosh. 5-day admission, hardcore chemotherapy, high chance of readmission. There's a lot of harms to the patients. And this isn't something that I focused on. I wanted to keep this part sort of brief, but there's a lot of harms. There's longer hospital stays for the actual transplant. There's more infections for the transplant, more antibiotics used. So post-transplant outcomes, like the acute toxicities are a little bit heightened when you hit somebody with really hard chemo right before their transplant. As you might imagine, it's not, it doesn't make their life easier when they actually go through the transplant. You're kind of knocking them down a peg, so to speak. So yeah, there are real harms to the patient. I wanted to focus on the primary objective, which was the EFS, but yes, there are real harms.
So Andrew, I'm hearing what you're saying about the clinical culture and how it impacts whether a patient who's otherwise eligible for either receives the intense mobilization. And would it be correct for me to guess or assume that that any of you and others who are in myeloma practice, there's not a one of you who would prescribe both, depending on the circumstances, or is it so split? That there are some docs who never use the intense mobilization, and others who.
Yeah, good question. I can only speculate. But I would say that probably what has happened is there are a couple of people that have really believed in this practice and they do it routinely. And then there are people that are like, let's go with the default. Like, why do we need to do this? And patients with bad disease status just pass through. And so it is very clinician dependent. Some of it's, it's very expert opinion based. And people who decide not to do it, or I think sometimes it's not even a decision, they just don't really think about it and they slip through. I think some people do think about it and they say other centers don't do this, and so why should we do this? Because it's not an NCCN recommendation by any means to do this. It's really a Hutchism. And so not doing it is not a crazy thing.
Understood. So it wouldn't really be possible to include physician in some.
We thought about that, but thought it would be a little bit too personal. That's true. But also there's some people who've been here for like 20 years and other people who've been here for a year. So it's actually a little bit challenging to look at that. But basically what I'm trying to show with the sensitivity analyses is that when you look at these valid potential criticisms of the modeling, you get a very similar result when you analyze the data in these 6 different ways. And so intensive chemomobilization, high-risk myeloma, what did we learn? Well, it's used selectively in patients with high residual disease burden, and these patients differ markedly from patients who receive the regular mobilization with GCSF and plerixafor. So propensity score matching was necessary to address the strong confounding by indication, because the patients who get the intensive chemomobilization are just totally different than the regular patients that don't. And so multivariable adjustment alone doesn't tell the whole story, because it's looking at the independent impact of chemomobilization. It's not looking at the average treatment among the treated. So we want to know for the patients that get it, did it help them? Not in a general sense, is it beneficial? If somebody has these particular disease features that are like the patients that get it, is it useful? And every way that we look at it, the answer is, much to the chagrin of the transplant leadership, it is useful. And so we are still doing it. So let's see, some methodological strengths. So you really want to have a single pre-specified primary PSM analysis. You want to separate the design and the, No, the hazard ratio for EFS was 0.3. So we saw a very marked benefit in every model with the intensive chemomobilization. But when we did the unbalanced, the non-PSM analysis, it was essentially like a wash. But then this is our primary analysis, we see a hazard ratio of 0.3. And then when we look at all the sensitivity analyses, we see very comparable effect sizes with every sensitivity analysis compared to the primary analysis. Yeah, make sense?
Yes.
Okay. So each sensitivity analysis really should address a specific concern. It shouldn't be random. It shouldn't be throwing everything at the wall and seeing like, well, it sticks this percentage of the time. It can't be that. It needs to be very deliberate. And so you want to see a consistent effect size across specifications. And so the main findings are that we see improved EFS after adjustment with propensity score matching. And the results were robust across all the sensitivity analyses that we could think of. It's still an observational design. There's residual confounding from unmeasured factors. You would obviously need to have a randomized control trial to really conclusively reach the effect size that's real. And another limitation is that there are still a small number of patients whose disease features really couldn't be adequately balanced. There are some people who got chemomobilization that were just so high risk. There's no conceivable way to balance them. You can't match them. And so I think the fact that the chemomobilization group still had worse features, even after we balanced as well as we could, I think it actually makes the argument even stronger that there is a benefit. So switching gears, and I know we don't have a lot of time, I wanted to focus on that because I think the propensity score matching can really change how you think about a data set. The IPTW can sometimes be like the icing on the cake of another analysis. So in many real world settings, the treatment groups are imbalanced, matching would discard patients. And so you want to look at a population level effect, not just the treated patients. And so as we've been discussing, the propensity score matching lets you look for a treatment effect among a group that gets some kind of special treatment. IBTW is used to estimate the average treatment effect. So instead of looking at what is the effect of treatment among those who received it, what is the effect of treatment if we applied it to the entire population? And so if everybody got treatment X, is it better than if everybody got treatment Y? which is different than what we did in our propensity score analysis, which is if everyone who was eligible for intensive chemoembolization got it, would it be beneficial than if nobody, more beneficial than if nobody got it? So this is a case study of a real world comparison of CD19 CAR T products in large B-cell lymphoma. So comparing Breyanzi or Lysocell to Yescarta or Axicell, which are both FDA approved for the same indication, large B-cell lymphoma. But there's non-random treatment assignment that's driven by age and frailty and disease burden. And so we wanted to estimate the independent effect of CAR T selection while retaining the full cohort and minimizing treatment allocation bias. And so this was a study of all adult patients with LBCL who received either Lysocell or Axicell, these two competing CAR T products. And we looked at everybody who got either of these before 2024. And so these are the baseline characteristics. The things that kind of stand out is that patients who received Lysocell were about 5 years older, and there were different responses to bridging. So what's bridging? So basically you get leukapheresis, so you collect your T cells, and then you have about 4 weeks before you proceed to get lymphodepleting chemotherapy and then CAR T cell infusion. And so there's this sort of donut hole in time where people get more treatment. And we call that space the bridging period. And if somebody doesn't respond to bridging chemo, then they have worse disease status going into CAR T therapy, and that's generally not a good prognostic sign. And so, when we look at the percentage of patients who got no bridging or who had responses to bridging, it's different based on Lysocell and Axicell. So more patients in the Axicell group had no bridging, or in other words, fewer patients had bridging who received Axicell. And then the percentage of patients who achieved responses to bridging was higher with Lysocell. So these are a little bit different patient populations. It's just kind of reflecting that the disease biology is a little bit different between these two groups. And so what if we do IBTW and we balance these two groups? And so these are the things that we adjusted for. So age, bridging response category, so no bridging, response to bridging, unknown response to bridging, or standard stable disease or progressive disease in response to bridging, having a history of a prior transplant, whether or not the CAR T was used second line or not. Certain parameters then indicate disease aggressiveness, like absolute lymphocyte count or lactate dehydrogenase, whether it was a transformed DLBCL versus another type of DLBCL, if there's extranodal disease, the largest lesion size as a continuous variable, ECOG performance status 2+ or not. And so everything balanced pretty well. So the line is at 0.2 here, and so everything was less than 0.2. So there were some things that had mild imbalance, but overall it was pretty well balanced. Usually it's easier to balance things like with IBTW than it is with propensity score matching. The variance ratios, we see that there are some that have outliers, nothing that crazy, but with LDH, this is the LDH pre-leukapheresis. There's one outlier, and same with ALC. There's one outlier, which kind of screws it up a little bit, but I'm just trying to show you that in general, they are fairly well balanced, except for like one patient. And so what does this actually mean? What is inverse probability of treatment weighting? The idea is that you're using the inverse probability of weights, you're taking the inverse probability weights, so you're weighing people more heavily if they were less likely to receive the treatment that they got and more likely to receive the alternate treatment. And so if a patient gets Axicell, but they were very likely to get Lysocell, we weight them high. And if somebody's very likely to get Axicell and they get Axicell, we weight them low. And so that's kind of what this is showing. And so if somebody's really likely to get Axicell and they get it, we weight them low. If somebody's really likely to get Axicell, but they get Lysocell, we weight them high. I'm not sure if I'm saying that. Does that kind of make sense? So we're basically weighting people higher if they're more likely to get the opposite treatment. And in this way, you're weighting people who kind of get the middle ground higher. And this allows for improved balance. And so it's basically 1 over the propensity score or 1 over 1 minus the propensity score. And then you have to use a scaling factor. So you generally have to use stabilized weights. And this is a way of ensuring that the average weight is roughly 1, so that the total number of units in each group is preserved. And this is a way to translate this approach into downstream, like not effect sizes, but confidence intervals that are like reasonable. And so you have to generally use stabilized weights. And so there has to be a scaling factor to normalize the weights to the relative sizes of each, to the treatment groups. And so when we do this, we can improve the balance really markedly. We can get the ages to be basically the same. The bridging response categories now are pretty well balanced. The ECOG performance statuses are basically identical. And so we can do a pretty good job, compared to the unweighted to the weighted. And so what do we see when we do this analysis? We see that there's way more toxicity with axicell. And so cytokine release syndrome, this is kind of like septic shock for patients who get CAR T therapy, way higher with axicell. The red is grade 4, grade 3, grade 2, grade 1. And so we're seeing, more higher grade, more total with CRS. And so we see, grade 1, the adjusted overall odds ratio is 4.3. For grade 2 plus, it's 2.9. And so we're seeing way higher adjusted odds of grade 1 plus or grade 2 plus CRS. With ICANS, we're seeing more ICANS. And then this is hematotoxicity. It's blocked here, but there's way more hematotoxicity with axicell than lysocell. And so basically every way we look at this, there's more toxicity. And so one thing that I think sometimes gets forgotten about with these propensity score-based methods is that it's not just for looking at response or durability of response, but also toxicities. So it's a way to compare and contrast toxicities too. But in terms of response, the response was identical. So it doesn't get much more identical than this. The adjusted odds ratio is 1.1 for overall response rate and 1.1 for CR or better. These are basically the same. When we look at durability of response, these are adjusted Kaplan-Meier curves based on the weights from the IBTW model. Not significantly different. Either progression-free survival or overall survival. There's maybe a trend towards better overall survival with lysocell, but it's nothing really significantly different or clearly different based on the data set. Sensitivity analyses. So I'll just sort of jump right in. We did a bunch of sensitivity analyses, and ultimately the thing that we focused on was the toxicities. So we did a contemporaneous analysis. So axicell came out first and lysocell came out second. And so maybe we just had more experience by the time we started using lysocell because it came out second. So if you do a contemporaneous analysis that restricts the analysis to only looking at when they were both available simultaneously in the market and in use, that's the green. And so we don't really see much of a difference. So this is overall survival, duration of response, relapse, PFS, same. CRS, we see that if we restrict to the contemporaneous, it's actually potentially worse, but a wider confidence interval. CRS 2+, exactly the same. So really quite similar. One thing that's different is that the hematotoxicity becomes non-significant, and that could be because we now use GCSF more often to support neutrophil count and reduce hematotoxicity in contemporary practice than we did several years ago. When we include inflammatory markers, so CRP and ferritin at day 0 into the IBTW model, that doesn't really change anything. When we include SUV max, so this is a sort of a marker of, if we look at the biggest lesion on a PET scan, how metabolically active is that lesion, and we incorporate that into the model, it doesn't really matter. We see that the durability outcomes are identical. The toxicity, the CRS is worse. ICANS in some models is worse, but is generally, it's some models it's worse and some it's trending towards worse. So we're seeing kind of same directionality of response. The only thing that kind of sticks out is the contemporaneous analysis, that the hematotoxicity becomes less different. And like I said, probably that's a result of changes in supportive care practices over time. So the contemporaneous analysis in this case was sort of an interesting thing that it did maybe shed light on at least one of these toxicities that is now being mitigated. So what did we learn here? Well, the treatment assignment, it's non-random. Patients received different CAR T products based on their baseline characteristics. And we needed a population level comparison. We want to know should we use one for everybody? Should we use a different one for everybody? Is the axicell has more toxicity, but does it pack more of a punch too? Or do you just get toxicity for nothing? And it seems like you just get toxicity for nothing, unfortunately. And so why was IBTW appropriate? There's strong confounding by indication. And so IBTW preserves the full analytic sample while addressing the imbalance. And so it's an elegant method to address these differences in baseline characteristics and driven by treatment allocation bias. And so we created a weighted pseudopopulation in which treatment is independent of the measured covariates. We achieved improved covariate balance. and it enables us to estimate the average treatment effect. And I kind of think about the average treatment effect and the average treatment of the treated kind of like these concepts of like, what are we really going for? With average treatment effect, we want to know if everybody gets one thing, is that better than if everybody gets the other thing? And in this analysis, it suggests that liso-cel is generally better in that it's less toxic. It's still a retrospective design. We can't fully capture frailty, and probably the liso-cel patients have unmeasured frailty that we can't easily extract from a number in the chart, which actually maybe further, again, probably the liso-cel patients are worse off in certain ways. There's treatment error effects that we can't totally capture even with a contemporaneous analysis. And we're, in some ways we have limited power to detect small efficacy differences or toxicity differences. So there are still some limitations to this. So how do we know an analysis is right? This is sort of a philosophical question. There's no definitive analysis, no single analytic method, or even when you have 100 sensitivity analyses, assuming they're all good, it doesn't necessarily guarantee truth. Causal inference rests on assumptions, not randomization. We don't have like a time machine where we can try different things and see what is better. But confidence comes from convergence. And so when you have independent data sets, if different investigators, different centers reach the same conclusion, if people use kind of similar frameworks and find the same effect with different populations, and if people arrive at the same qualitative conclusions, then that builds confidence that an analysis is right and that the conclusion is real. And so, why this matters, it reduces the likelihood that results reflect model overfitting, specification searching, or p-hacking, and center-specific practice patterns. And so, if you see a convergence of results, it shifts the interpretation from this model worked, and we got a conclusion that's significant, to this signal is real. And so I was really pleased to see that a couple of months ago with the IBTW comparison of lysosome and axicell, another center did a bigger study and arrived at the exact same conclusions. And so I think this is often what it takes, that multiple groups have to do the same analysis and reach similar conclusions, or if there's a difference, one has to justify why their analysis is better. So the final takeaways, real-world treatment assignment is inherently non-random, and so confounding by indication is unavoidable. Propensity score methods are essential to enable valid comparisons, but they have to be used thoughtfully and transparently because you can reach the conclusions that are not real and not supported. And then the method selection has to align with the causal question, including the target estimand, so ATT or ATE. And then, the case series I presented hopefully illustrate these principles in practice. And I think the final take home was that confidence comes from convergence. And so if the findings are stable across different similar analyses, if different groups are arriving at the same conclusion, then that makes things more likely to be quote unquote true. A lot of thank yous, too many to count, but special call out to Ted and Vicky and Phil and people in the biostats group that have tolerated me stumbling through this and slowly but surely figuring out how to do these kinds of analyses. So thank you.